Okay, now we're back to tracheotomy or tracheostomy. This is where they're actually creating a stoma or an opening. The reasons that they may do that is to bypass an obstruction, facilitate secretion removal, or it's someone with permanent long-term mechanical ventilation. It can be created surgically, which most are done. It also can, once the patient has had it for a while and it is long-term, they can get different apparatuses so that they can speak once the cuff is deflated. They come cuffed or non-cuffed. The cuff plays an important role if you have a patient who is a risk for aspiration. The cuff actually puffs up and it blocks in their airway so they do not aspirate on their own secretions, because that is possible. Cuffed is needed if the patient is going to be on mechanical ventilation. It is also inflated with a minimal amount of air, and two of the techniques that they use is called MLT, which stands for minimal leak technique, and MOV, which is minimal occlusion volume. When we're talking about an actual trach and you're going to have to deflate the cuff, and there's a picture I think on the next slide that I'll pull up, and we'll talk about the actual components of the trach. Before you deflate the cuff, you actually have to have the patient cough up secretions. You deflate it during expiration. You do need to suction secretions and assess for aspiration. If that patient is at risk for aspiration, you have to reinflate the cuff, and you do that during inspiration. You need to stay with the patient initially when the cuff is deflated. So this is the parts of a trach tube. So all trach tubes have a face plate or a flange, and that's what you see right here. They also have trach ties. This one has an outer cannula, and this is the cuff when I was talking about deflating the cuff. This is the cuff that's deflated. The little pilot balloon, or the where it says one-way valve, is the source that you use to inflate and deflate that cuff. The other thing is you have an inner cannula and you have an arburator. The arburator is important. Think about, I think one of the students in the other class thought of it as the angiocath. This is, think of the needle inside the plastic hub. This goes into the inner cannula in order to insert into the trach or the stoma site, and then the arburator has to be removed quickly because that's what allows the air to flow. But it's stiffer, so it's used as the guide. The arburator is something that you need to keep by the bedside in case the trach comes out. With the trach itself, you want to change or clean the inner cannula and stoma every 8 hours. Some of the inner cannulas are disposable, so you don't have to necessarily pull them and clean them. You just replace them. Suction's needed. There's always suction if someone has a trach at the bedside. The other thing that needs to be kept at the bedside is a smaller or equal size inner cannula and the arburator. If that trach becomes dislodged, you have to attempt to replace it. So you would insert the arburator into the inner cannula, because that's the part that's going to come out, and try to put it back into the stoma, but you would lubricate it with saline and insert it at a 45-degree angle. You can also use something called hemostats or Kelly clamps, which are kind of like, they have a lock on them, so they're like scissors with a lock to open the actual site or the stoma site. If you cannot replace the tube, you need to cover the stoma with a sterile dressing and ventilate the patient with a bag mask. However, if the patient had a total laryngectomy, you need to ventilate them through the stoma. This picture is showing you the cuff inside, the trach actually inside, and what the cuff looks like when it's inflated. And you can see that it's almost like a stopper so that the patient does not aspirate on their own spit, because we're mechanically ventilating the patient. So we're giving them their airway through mechanical ventilation. There are different types of trachs and nursing management. That is on page 508. 27-5. And then we have suctioning a trach, which is on 509. 27-6. And then we have page 510, trach care, 27-7. And then you have delegations, who can be delegated what when we're talking about trachs. And that is on page 518. All of those you do need to review and be aware of. So once patients have had a trach, and this is long-term therapy, and they're over the respiratory distress part, there are different mechanisms or different types of trach tubes that allows them to speak. There's also speaking valves that can be placed. One of the types of tubes we're going to talk about is the fenestrated trach tube. This actually, you can see the cuff is deflated, and it allows the air to move up because there's a little hole, which is the fenestrated part, in the actual inner cannula, and it moves up the trach, and it allows a vibration, so it allows the patient to talk. So one of the things is this patient who has a fenestrated tube, it's used for patients who can swallow and are not risk for aspiration. And usually assessing risk for aspiration is done by speech therapy, video fluoroscopy, or a fiber optic endoscope to assess this, because we do not want to risk judging or guesstimating someone's ability to swallow and they end up aspirating, because these patients are already compromised anyway. So this one is an opening surface of the outer cannula that allows the patient to breathe through the larynx and speak, and they can cough up secretions while it's in place. So that's what makes it special. So this is also listed when I told you there's types of trachs and nursing management. This is one of the types that is listed there, and it goes over how it works and what's your responsibility. And then just know that there's also speaking valves that can be put in place once a patient has had a trach for a while. So this is going to wrap up. I did skip a lot of slides. Most of your slides are just kind of the breakdown of your boxes of suctioning and trach care, and that's something you guys can review on your own. And then we will do pediatric upper respiratory next.